Next two cases will be operated by Professor Dr. Amr Azab and Professor Dr. Ayman Shuman. The first case is a male patient, 52-year-old, presenting with right complicated cataract surgery. The best corrected visual acuity is 0.1 with using +15 lens. Intraocular pressure is 14, diagnosed as right aphakia and dropped nucleus. And the plan of the surgery is to do right pars plana vitrectomy, fragmentation of the dropped nucleus using a combined 20 and 23 gauge vitrectomy, and sutureless clear fixation of 3-piece IOL. The combined technique of the 23 and the 20 gauge because we don't have a 23 gauge fragmatome. This is the first case, and this will be operated by Professor Dr. Amr Azab. The second case is a female patient. This will be operated by Professor Dr. Ayman Shuman. She's a 70-year-old, previously made bilateral cataract surgery, and she's complaining of defective vision and metamorphopsia. Visual acuity is 0.3 in both eyes, and she was diagnosed as left epiretinal membrane. The plan of the surgery is to do left pars plana vitrectomy through a sutureless 23 gauge system plus epiretinal membrane and ILM peeling. And this is the OCT of the patient. And this is the fluorescein angiography of her. So let's wish them luck. أيمن صباح الخير.
صباح الخير يا إيهاب. Good morning everybody. Inshallah, I'm starting with 23 gauge sutureless vitrectomy in epimacular membrane.
Yes.
It's post-pseudophakic cellophane maculopathy, as you have introduced the case.
Okay. Ayman, can you tell us about the instrument that you're using to make the incision?
Yes. I'm using 23 gauge trocar and cannula, the one step from Alcon.
Yes.
I'm using a fixator plate.
Okay.
I use the back surface of the trocar cannula. It's got the marker, This one is at 4 millimeter, and this one at 3 millimeter for the pseudophakic case. So I just mark it. I usually enter just below the lateral rectus. I fixate with this instrument, the eye, and I go usually with the flat side of the trocar. I usually like to go at 5 degrees.
This is your degree of angulation, yes.
Yes, I don't know, is the view clear for you? Okay, give me a Q-tip. Just sometimes the eye is going back, it's got too much redundant orbital fat, so I'll just fixate on the opposite side, go inside, 5 degrees, and then go for 30 degrees, and then introduce it inside. Release my cannula, and then put my infusion open. Have to check, of course, for any airs. Okay, filling. It's a bit edema. Okay, so. The same idea up. I just measure, اديني الكيوتيب. Measure still with the back surface, which got the caliber on the trocar and cannula. Mark it. Fixate the eye with the Q-tip, and then I fixate opposite with the Q-tip. I don't usually move the conjunctiva, as we all learned starting this style of incisions. I found it not that beneficial. I go 5 degrees and then 30 degrees, and I enter the eye 30 degrees. Usually just above. We go just above the lateral and medial rectus, not like we do in the 20. We go more towards the horizontal side so that we can have more versatility in using our machines. Do you need Q-tip? The same over here.
Mm-hmm.
I go from here. Okay. Centralize, Sharif. Centralize, please. Methane on the surface of the cornea, please. Sorry. Mm-hmm. Show me. I'm starting my vitrectomy. Okay. Open saline, yes. Okay, Zilidino. Just a minute. Focus, please.
Ayman, in such cases, you're satisfied by doing just core vitrectomy, or you're planning to do total vitrectomy?
Almost. I do sort of a midway vitrectomy, a core and slight shaving, but not strict shaving.
Okay.
So that I don't leave. I don't like to leave a large skirt of the vitreous hanging, because it sometimes do even traction on the vitreous base. But I don't do full shaving usually in these cases.
Mm-hmm.
I'm starting now with I'm using an Omira microscope with the indirect biome from the eyes.
Yes.
اقلبي الثانية لو سمحت يا دينا، العدسة الثانية. Yes. اديني focus please. Focus. لا فوكس زي ما اعكسي. What's wrong? حاضر. لا اعكسي يدين. حاضر. اعكسي يدين انزل. كمان بس حلو. كمان سنة صنوع. Very good. Is the picture okay now?
Yes.
I'm using the electric cutter with the at the start point of 1,500 cuts per minute and the end point at 5,000 with a linear vacuum from 0 to 300 on the Constellation machine.
Okay.
I'm using the core duty cycle.
دكتور أيمن مع حضرتك أحمد سلام من
سوري؟
مع حضرتك أحمد سلام هو اسمي أحمد سلام
سيرجن.
أهلا وسهلا. كنت عايز بس أسأل حضرتك أنت متوقع إن في PVD في الحالة ديت مش كده؟ لأن هي epiretinal membrane. Or you would routinely go and check for PVD in these patients?
Yes, but I have to check, and a lot of times I inject triamcinolone. I'm one of the advocates of triamcinolone.
Okay.
Because I get afraid usually from the vitreous cases. I find it a lot, especially in diabetic patients, of course, but you can never tell. Sometimes you get a whole sheet in some cases. It's seen that this case might have, as you have mentioned, has got posterior vitreous detachment already.
Yes.
But sometimes you can't tell really. اديني فوكس يا دينا. العكس. اقلبي لي العدسة أو العدسة الثانية please. I'll go for the 90-degree lens, which gets me focus, good picture of the posterior pole and the optic disc. حلو كويس أوي. Stop it.
So you're checking for PVD now? Or?
Yes.
Yes.
I'm checking for PVD from the nasal side.
Right. But you expect from the appearance that she probably had PVD?
Triamcinolone. I'll use it right away. Triamcinolone. I'll use triamcinolone to get a demo of it. Just a small, yes. No. Just a small amount, so that we leave it to disperse on the posterior, on the surface of the retina. I usually shake the eye as if we're shaking something in a fluid. Just wash it away to leave just a small remnant to the surface. As we all know, it doesn't stain the surface, it just entangles to the surface of the posterior vitreous face. But what I'm seeing, there is no entanglement. Most probably, we have a total PVD, as Dr. Salam has mentioned. So I'm pretty much satisfied with this to get sure that we have a posterior vitreous detachment. الصبغة جاهزة. Okay. نقلب هواء. I will change to air, doing fluid air exchange.
So you're staining under air.
Yes,
Yeah.
this is trypan blue. I'm using trypan blue 0.18%. Usually it's lighter than its density. يلا هوا. Its density is lighter than saline or than lactate or BSS that we're using. So if you inject it, you either do it like this or you chill it in the refrigerator so that it's got a denser density, and you can inject it while turning off the infusion so that it precipitates on the surface of the retina.
Okay.
But I usually prefer doing fluid air exchange. It gets the staining better and the contact with the membrane and the ILM better. Usually membrane blue or trypan blue stains better the epiretinal membrane than the ILM, as it stains better the dead tissue. So focus.
And now which stain you will use?
trypan blue 0.18%.
Okay.
فوكس لو سمحتي. تمام. عكس عكس. عكس. يس. اوكي. معاكي فلويد نيدل 23. استنى انا عكس كنسل. Okay, no. Stain, yes. You just put a small puddle of the dye over the fovea. Leave it for 30. I usually leave it for 30 to 60 seconds. If you need them. I'm waiting for the dye to stain the surface of the epiretinal membrane to get it more delineated. You can try to use, of course, removing the membrane on the maculopathy without the stain, but the problem is that sometimes you leave parts of it because there are some parts which are more opaque than the others, so you can leave parts of it. So I usually prefer doing it with dye. To get sure as much as I can, I left nothing. Oh, okay. I removed it. نقلب هوا لو سمحتي. Yes. I'll change into saline يلا. I removed it with the fluid needles to avoid its dispersion, and then I will turn in again into fluid again. نمسح العدسة يا دينا. Oh yeah, just wipe and put methyl. ثبت لنا ده فين ثبتي والنبي الموس. You've got a movement on mine. Okay. Okay. ناخد لا ثانية واحدة. ارفعي ثانية واحدة يا دينا، ارفعي ثانية واحدة عشان بس أنا فين؟ just a minute. اقلبي لا الانفرتر القلاب. Yes. Just removing the remaining air behind the lens. اوكي توم عشان بس يروح لحظة.
Can you tell us if you have a special site where you start peeling the membrane from?
Usually I try to go as peripheral from the foveal area as I can.
Okay.
If I can I can get any potential space or cleavage line between the membrane and the surface of the retina. If I can't, I get as near as I can to get an edge. If I can get it from the remote spot, this would be of course better to avoid pinching the fovea, because we usually pinch the area. يلا مثال يدينا. Just removing the air from the anterior vitreous. Yes. لا برا مثال برا. اوكي. يلا اديني اخش جوه شوف. Focus. Okay. Forceps. I've got a good view with the. Sometimes I go with the biome
Yes.
if I can see well. Yeah, I have some choices to make. Sometimes is this obvious? You have.
Yes, it is.
I've got, you see, a redundant part of the membrane, which is very good to hold.
Yes.
This is very good to hold instead of finding. I was talking about a potential space to get it. Thank God it's already rolled on itself.
Yes.
This is a good thing to
Yes.
start with instead of pinching the retina.
You're a lucky guy.
Yes, thank God. So I'll hold it from this redundant or elevated area
Yes.
with the forceps. See the staining is rather nice, as I can see. Do you see the staining good down there?
Yes, yes,
very
it is. Very nice.
So I'm using the biome with the 90 degree lens. It's good.
And
If
I think
can
it's
see-
quite efficient.
Yeah, I think so. If it's
Yeah.
not, I would get the self-maintaining
Macular lens.
Yes.
Mm.
Got a small bleeding spot.
Okay.
My forceps down.
You're using an ILM Eckert forceps, huh?
Yes, an end gripping forceps. I'll use the one I'm introducing now is the Eckert one. This is the Eckert. فوكس يا دينا لو سمحتي سنة صغيرة بس. It's rather tight, by the way.
Yes.
I'm holding a grip and it's tight, really.
It's elastic, yes.
It's coming piecemeal. This is a bad thing because I then have to pinch every now and then, and I'm pinching in the foveal area, which is not nice to do. But it's coming piecemeal. It's not coming one mess. I won't go to the fovea again. I will start more peripheral to pinch an area between these two blood vessels. Maybe I'll get. Yeah, it's very tight. I think there's even 2 layers, maybe a layer of the membrane itself and another layer of the ILM. Sometimes you get membranes that you hold it and you remove it all in one piece. But usually during conferences you get the hard time. Here when you go to the periphery, you get a less tight adhesions, so you get a more easier removal really.
Well done يا صديقي.
Usually this spots of hemorrhage don't worry us because it's from the surface attachment of the membrane or even the ILM, so we just leave it, and I'll just do backflash inshallah for it with the fluid needle. Fluid needle again. Harder. I've got the fluid needle with my hand. Just flush away this blood as much as I can, because I like to do. I will do an extra. Maybe we've got, as I said, more areas of membranes that I didn't remove, and maybe the ILM got small areas still remnants. So I will do staining again of the eye to get sure that I removed what I want from the membrane or the ILM. It's better to move the ILM, really. I'm one of the advocates of removing ILM because it gets you, as a scaffold or needles, to even have another time membrane or a cellophane maculopathy again.
Okay.
هوا لو سمحت يمينه يتوم الأول واديني هوا.
And you're gonna use tamponading Ayman by the end of the surgery?
I'll check the periphery. If I don't have any breaks, and if I don't do any iatrogenic breaks in the center,
Yes.
I will just leave air.
Air.
Just air.
Okay.
I won't
You
leave,
don't use gas.
I use gas only if I have peripheral tears
Okay.
that I find from my entry, or if I do any iatrogenic breaks in the center, I get afraid really. So I put SFS F6. It won't hurt, and it will tamponade me the eye. But if there's no any iatrogenic breaks,
You just leave air.
yes.
And you don't lace the periphery except there are iatrogenic breaks.
Yes, if I find any.
Okay. دكتور عمرو الحمد لله على السلامة.
Now I have a case of accidental aphakia due to dropped nucleus.
Okay.
You can see the nucleus is moving behind. And I'm intending to do him vitrectomy, fragmentation of the dropped nucleus, and if I'm lucky enough, will do clear fixation, sutureless clear fixation. Because even the REM is not enough to hold an IOL.
Okay. So you started as a full 23 gauge, and then you will open the 23 to to use the 20 gauge fragmatome, right? دكتور عمرو.
احنا نستنى زياده عشان السكين
طيب ماشي.
We're now back with Dr. Ayman Shuman doing the epiretinal membrane peel.
Still with me? Are you still with me? Can you focus?
Yes, we can hear you well. Dr. Ayman حضرتك حطيت air دلوقتي و staying under air مش كده؟
Yes, yes. اللي بيدو هوا أنا آسف صراحة الناس I'll change I'll get fluid again. I waited for 32 seconds to 1 minute. ارفعي كده عشان نشيل yes very good. شوية مثال على الوش كده. اوكي عشان اجيب الحته دي بس. لا لا
You double stain as a routine, Dr. Ayman.
Sorry, Dr. Saleh?
You double stain as a routine.
Yes, yes. Usually I do it as a routine.
Okay.
Yeah. Really? Really? تفضل بيه تفضل بيه تفضل بيه. حلو.
اوكي دلوقتي عمرو معايا. عمرو معايا. اتاكد ان الصوت واصل بس عنده. طب بص نقدر نستنى. دكتور عمرو حضرتك سامعنا؟
ايوه انا سامع.
طيب تمام.
النور مش منور. لايت. بس خلاص اوكي.
We can see it now clearly, the drop nucleus.
Yes. I have a very narrow pupil. They are
Yes.
starting to put mydriatic now adrenaline على المحلول. I think the view is enough. Focus.
Dr. Amri, you're doing total vitrectomy before, or you just leave like a vitreous cushion behind the
My
nucleus?
policy in such cases is to start doing core vitrectomy above the dropped nucleus,
Yes.
and not to do BVD or posterior vitreous detachment, because in such conditions I need the cushion of vitreous behind me to prevent the repeated
Fall down.
friction and fall down of the nucleus during the operation. Let's focus. ونطفي النور اللي ناحيتي. بعد فوق شوية. بس. لو مش عايز صوت في الأوضة صبح، لو مش عايز صوت في الأوضة. اوكي يلا شيلي هاتي الانبيار. Of course, we don't have fragmatome in 23 gauge now available in Egypt. Our colleague in the institute, Professor Dr. Ihab Rais,
Yes.
have invented one of those. I don't think it is available till now, but it is in the pipeline and it will be available soon.
Yes.
So I'll use the fragmatome, the 20 gauge fragmatome, and I'm increasing the gauge of the opening now.
Dr. Amr, one tip to share with you and with the audience that was shown to us in the last retina meeting in the UK by David Steele, who is one of the pioneer surgeons in the UK, is to put heavy liquid and using the light pipe direct the nucleus to the antechamber over the heavy liquid, and then using the Alcon Infinity or the Alcon Constellation phaco with the ozil phaco in the pupillary plane, and usually with the ozil you have a good purchase on the nucleus and it doesn't
Okay.
fall and you don't convert.
My humble opinion about this kind of surgery, that when I tried to do it many times, the perfluorocarbon pushed the nucleus in another
the
direction, which is against my will. It pushes the nucleus toward the periphery,
Yes.
and the nucleus stay in the back surface of the iris at the pars plana, and I don't see it anymore.
Yes.
So
I mean-
I am totally against the use of perfluorocarbon to flotate the nucleus.
Yeah, I think the trick he was shown is to inject with
Yes,
the
of
cutter.
course,
and direct with the
one
light
who
pipe.
showed, I think in his hand it works, but in my hand, unfortunately, it didn't work.
And especially if you have
Vacuum.
a small pupil, definitely you will not be able to handle it.
So you take the nucleus to the mid-vitreous?
Yes, I take it to the mid-vitreous. I don't like to direct my ultrasound toward the macula, and I activate the ultrasound in the mid-vitreous. All
Okay.
the time, I am aware that this needle is very hot.
Yes, that was the next question. How can you overcome the heating effect of the fragmatome at the
Yes,
sclerotomy sites?
I always ask the assistant, خليكي معايا بقى، حطي saline عند الانسجن. I do saline to cool down the tip at its entrance to the sclera. Otherwise, you will end out with the scalded sclera.
Yeah.
The other thing that you see now is every time the probe does not have something closing it, it causes excessive suction. And this suction makes the globe collapse. So you insist all the time to feed the probe with the nucleus.
What's your ultrasound parameter?
ايوه الباور مش السكشن، الباور الفاكيوم زي ما هو.
What ultrasound parameter do you have, Dr.
Sorry.
Ultrasound, what's the ultrasound parameter?
Yes, it's very, the sound is not here, but it's working.
What's the figure on the machine for the ultrasound?
The machine I use for fragmentation is the Accuracy, the old one, the gold standard of vitrectomy. افتح العدسة بسرعة، انزلي بسرعة.
You don't like to inject viscoelastic to cover the macula?
I already left the vitreous in front of the macula.
And you think that's enough?
Yes, I think
Okay.
that's enough. خلاص ما فيش سلام تاني، امسح العدسة. انزلي.
Okay.
Okay. Now we are done with the nucleus. We'll deal with the small fragments and with the rest of the vitreous. أيوة constellation.
Hmm. And are you insisting to do full vitrectomy?
No, in those cases you just aim at do core vitrectomy to remove the central part.
Yes.
You don't have to go for vitreous-based shaving,
تمام.
but of course you should do extensive vitreous base examination for the
Mhm.
periphery of the retina,
Mhm.
because in those cases you have difficult time during the first operation. The surgeon, of course, tried many times to trace the nucleus, and by this time, using the phaco tip, he entangled vitreous in the tip, and it may cause traction and peripheral breaks. Many times he have like a dialysis, which is not apparent, except after you do the vitrectomy and you remove the vitreous, it causes RD, because the fluid now go inside this dialysis. عايز كده أخد؟
Right.
كلهم يسكتوا. انزلي.
So Dr. Amr, you're checking for PVD now.
Yes, I'm checking. Almost there is no vitreous left. examine the periphery.
Okay.
أعمل indentation.
So you don't do a routine laser. Just if you find that it needs laser, you laser it.
Yes, if I find خف إيدك شوية. If I find break or suspicious area, I laser it.
Okay.
كملي. كملي. And also by searching the periphery, كملي, you may find some fragments left from the nucleus, which may cause continuous uveitis post-operative. So if you find any lens matter or dropped pieces in the periphery entangled, it may be wise to remove it.
Yes.
كملي. 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 خفي ايدك. كملي. كملي. خلاص كملي. 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 Okay. Now I finished the vitrectomy and the removal of the nucleus. I'll start now to prepare my field to implant the IOL. Or the vitreous. عايز واسكت. لا. لا أكن بدأت الناحية التانية. اعمل interview.
So now you're preparing for the scleral fixation.
Yes, I'll prepare for sutureless clear fixation.
And can you tell us what's the advantage of this technique concerning the sutureless clear fixation upon the normal
Yes, first
technique?
of all, for why in this particular case, as you, if I don't know if it's clear with you here, he has only a small rim here.
Okay.
From the capsule.
Yeah.
I'll enlarge the magnification a little bit. Yes, there is small rim here. So I don't have a rim down at 6 o'clock. So the regular sulcus fixation is not suitable at all for this case. Now I have two options. I left with either to put him an anterior chamber IOL, which usually the anterior segment surgeons do not like, even it has still has a place in those cases. If you have an excellent cornea like this, the cornea was not compromised by the first surgery, the cornea is clear and the patient is around 70 something. So you are not afraid to have a corneal decompensation on the long run. So it is still a valid option. The other option is to do the suture scleral fixation, which is the routine used all the time, but it has its complications. You have to put your stitches inside vascularized vascular tissue, which is the ciliary body and you may have bleeding, you may have a suture erosion and
Right.
falling down of the IOL at a later stage. Also, you have some cases, especially those with Marfan syndrome, who have a very wide corneoscleral angle, and particularly those cases which make me adopt the technique I will show now, because those patients, if you implant the IOL and try to fixate it to the sclera, you will have a long distance between the haptic and the sclera. And this distance, you should bridge it with the sutures. And this makes those sutures under tension, and the IOL rotate, and the erosion is more common. So I started to adopt this technique after seeing it in one of the conferences. I hope it will work well to demonstrate it to you now. Go tell me. بتاعته خلاص اشتغل.
Dr. Amr, can you tell the audience the steps of your procedure?
Now I'll make a mark at 6 and 12 o'clock, 2 millimeters posterior limbal. 2 millimeters posterior limbal.
Okay.
And this point I will enter with a 20 gauge MVR knife. I'll just remove this. I only need the infusion as a maintainer for the intraocular pressure.
Okay. So now we're 2 millimeter behind the limbus.
Yes.
And we're taking 2 stabs at 6 and 12 o'clock.
Yes.
الو
يا إبراهيم. يلا إبراهيم اتفضل.
دكتور ايهاب،
يس اتفضل أنا سامعك.
مساء الخير.
مساء الخير.
معانا الدكتور ايمن شومان، عايزين نساله few questions على the epiretinal membrane case. Does he really usually remove the internal limiting membrane in all cases of epiretinal membrane peeling or not?
I usually try to remove the ILM in all cases. Even in this case, I done staining, primary staining to remove the membrane. Then I redid another staining to see if there's internal limiting membrane is left. But I find that there's no ILM left because some cases you've got the ILM so much adherent to the epiretinal membrane so that when you remove the epiretinal membrane, it goes out with the ILM. But the direct answer is I try to remove ILM at all times.
Do you tamponade your patients, and which type of tamponade do you use?
Unless I find any peripheral breaks that I have done during entry with the trocars, or even posterior breaks, if I pinch the retina and do iatrogenic breaks, I usually leave air. If I found any iatrogenic breaks, I would leave usually SF6 because I don't need really tamponade more than 10 days or 2 weeks to keep the retina in place.
I noted at the end of the operation you had to take a suture in one of the sclerotomies of the 23 gauge. Is this a usual finding? How often do you do this?
In 23 gauge, it's not a usual finding, but I usually check. If I'm at the slightest doubt, I take a stitch. It won't hurt. Usually, we've got the feeling that we should leave it sutureless at all means. I think this is wrong. We need to have a safety for the patients. Just one suture won't do any harm. Even sometimes, in some cases, when I take a long time moving the trocars to and fro, especially in diabetic cases, sometimes I lose the valvular effect of the wound. I sometimes take 3 stitches. This happens in long cases, especially in the diabetics. So if I'm at the slightest doubt at any of the ports that I have done, I take a stitch. It won't harm, it won't take long, and it will make me sleep at peace by night.
Thank you, Dr. Ayman. Dr. Zazouk, do you have any questions for Dr. Ayman?
No, thank you very much.
Thank you.
Excuse me, Dr. Ayman, I just want to confirm that I do really appreciate what you've said. And
Dr. Saleh?
yes. And I was just saying that I would do a harmless suture, which will keep me good at sleep at bed. Thank you.
Yes, I agree with you, sir. Yes. Thank you.
Thank you, Dr. Ayman.
Nice. Dr. Amr, we're back. Dr. Amr?
أيوة.
Okay. This is the three-piece intraocular lens.
This is a 3-piece intraocular lens with a Prolene haptic.
Okay.
Now I'm retrieving the haptic outside the sclera. اغسلي.
Please try to position the cornea so as to be able to see at 6 o'clock.
Okay. Now I introduced the lower haptic inside the sclera. You can see it here. It is inside the sclera now. Whoosh. اغسلي. Okay. And now I introduce the IOL behind the iris.
So now you have the two haptics outside the sclerotomy site.
قللي النور هنا في الأوضة. I have only the lower haptic outside and implanted in the sclera.
Okay.
The upper haptic is not yet fixed.
Mhm.
على الريد ريفلكس. the IOL is secured in place,
Yes.
stable. You push from both sides. I don't think reflex is apparent for you.
Yes, it's very nice.
Yes. And the job is done like this.
Yes.
Bipolar. You don't need to close those sclerotomies.
Mm-hmm.
They do not leak. I just do bipolar cauterization for the conjunctiva.
And you make the tunnel to implant the haptics using
I use the 3 millimeter needle,
yes,
which is 23 gauge.
23 gauge.
Yeah. Okay, what is it? Shielding infusion.
You don't use glue like agarwal, it's enough.
It's enough. It's closed now.
Mhm.
Pressure is okay, and the eye is pressurized, and you don't need to do anything further.
It's beautiful surgery.
Injection.
Dr. Amr, there's a question from the audience. Dr. Amr? There's one question from the audience about the lower haptic. How was it, how did you fix it to the sclera? The lower haptic, yes. So could you, the inferior haptic?
We can't hear you. Can you speak to the... Can you hold the microphone?
Yes. For the lower haptic or the upper haptic, it is almost the same. The Berlin haptics are very forgiving. So they are very forgiving. So you just hold them. If you can hold them from their tip, this will be the ideal. And you pull them through the sclerotomy. You will see them bending very much. Don't be afraid, even if some piece broken, as many times happen, you can still thread the rest of the haptic inside the tunnel. The tunnel shouldn't be so long. It's enough to be 1 or 2 millimeters, and just thread the Berlin haptic inside the tunnel. And it stays nice and safe in this place.
So did you introduce, for fixing the lower haptic, did you
Yes.
introduce the forceps in the eye
Yes.
first before or while you're introducing the lens in?
Yes,
Or-
I first introduce the forceps through the lower sclerotomy. then I introduce the lens through the main incision and feed the haptic to the forceps. For this operation, there is two forceps, one curved and one straight. It's manufactured by Dork, and those forceps are the ideal for this operation. They have a groove in the tip, so you can hold the haptic securely without breaking it. But they are very expensive. It's like 3,000 Egyptian pounds, the pair of them. They are not sold solo, they are sold in a pair, one straight and one curved. But the one I just used is reusable forceps. It is a Russian made. It's very cheap and serrated tip. You can even use the one of the disposable forceps of Alcon to hold the haptic and to bring it out.
Excuse me, Dr. Am.
Yes.
The old sulcus fixation Prolene sutures,
Yes.
we had a guidance. We could introduce a 23 gauge trocar, so as we guide the needle while it's going in and out of the eye.
Dr. Saleh, sorry, I have a noise here. Please repeat.
Okay,
the
I will
question
repeat again.
Yes.
With the usual sulcus fixated IOLs, we used Prolene sutures in addition to a 23 gauge needle so as to guide the 10 millimeter straight Prolene needle into this port. So it's a bit of a guidance for us. Here we've seen that using the special forceps were for us a bit unclear. I mean, I couldn't follow you.
Okay.
What would you prefer to do?
I prefer this technique. As I said before, I have all the troubles during to fix the IOL with needles. I have almost always bleeding. I have sometimes rotation of the IOL. The IOL gets vertical instead of horizontal. I have a dislocated IOL to one of the sides. Here you are very much sure that the IOL is 100% in the middle of the pupil. It does not rotate, and it's not. You don't have bleeding at all inside the globe. The sutured IOLs, yes, of course, it passed the test of time. It worked very well for decades, but in my hand, it always caused me trouble, so I shifted to this technique.
I accept this fact, but bleeders are in both techniques are to be expected, but perhaps you have a better alignment of the IOL, less dislocations and so on,
Yeah,
which I should...
also the one situation I just mentioned during the work, the Marfan syndrome cases, those cases of Marfan syndrome, they have a wide corneoscleral angle, and the sutured IOL does not work well for them, and maybe this one causes that I shift. I have a couple of cases of Marfan with subluxated lenses, and you don't have enough rim at the end to implant, so I shifted to this technique, and it helped me a lot.
Thank you very much.
Thank you.
Anyone of the audience would like to add any remarks? Okay, thank you very much for your presentation.
Not correctable by glasses anymore.
Okay.
By examination, we find distortion of the macular area and straightening of the blood vessels, and we judged the condition that it is a sort of epiretinal membrane, which has many names in the literature.
available to be
Yes, I will put it
shown,
now.
To you.
Yes.
My plan is to do 23 gauge sutureless vitrectomy and peeling of the epiretinal membrane under triamcinolone, and then using BBG dye to remove the internal limiting membrane.
Okay, and which tamponading you will use by the end of the surgery?
By the end of the surgery, if I am lucky enough I don't have breaks, I will use air. Just
Only air. Okay.
If maybe I have a heterogenic break or something, I may use some longer acting gas.
Okay, thank you.
Thank you.
Our next two cases will be done by Professor Dr. Amr Azab and Professor Dr. Ayman Shuman. The first case, which Dr. Amr Azab already mentioned, is a 67 years old male patient with history of buckling procedure for rheumatogenic RD in the left eye since 8 years. He's complaining of metamorphopsia and defective vision.
عايز انزل الراس وارفع نزل الراس شويه يا احمد يا محمد.
Diagnosis is left epiretinal membrane, and the plan of the surgery is to do left vitrectomy and epiretinal membrane LM peeling. Here's the fluorescein angiography of the patient and the OCT. And this is the other case which Professor Dr. Ayman Shuman will do. She's a female patient. She's suffering from upper bullous rheumatogenic retinal detachment. Visual acuity is counting finger 50 centimeters, and the intraocular pressure is 8 millimeter mercury. The plan of the surgery is to do left pars plana vitrectomy and gas tamponading. Thank you.
Thank you. إيهاب صباح الخير.
صباح الخير يا أيمن، ثانية واحدة.
إن شاء الله be starting the second case of rheumatogenic RD, upper bullous rheumatogenic RD. I will do 23 gauge vitrectomy also with gas tamponade. I'll start putting my trocas. خليني بقى نديله الكيوتيب على طول. بدل ما نقعد نوجع دماغنا. كتب This is a fake case you have.
Yes.
She's got very mild cataract. I will leave it for a second step if it exacerbates later on. I'm entering at 4 millimeter, 3.5 to 4 millimeter usually in phakic, and I enter at 3 millimeter in aphakic or pseudophakic.
Okay.
I still do I still prefer in some cases doing conventional. In this case, we turned into vitrectomy, because it's very high upper bolus detachment, usually during convention we get some difficulty with this superior high bolus detachments. Also, what made me do vitrectomy or go for vitrectomy decision is that she's mildly cataractous. So being vitrectomy being postulated as a cataractogenic in itself, as a procedure method, made me go for vitrectomy. But if it wasn't that highly bullous, fresh, and phakic, I would
go for
conventional.
buckling. Yeah.
Yes, I would go for buckling. انزلي يدينا نقلب لا ثانية احنا عايزين كوب سوري لا ارجعي لي يا دينا كوب يس اطلع كده يلا كده كويس انزلي بالثانية يس يس اقلبي الأمر ادينا عدسة 90 يس اوكي فوكس العكس يس كمان more focus, more. That's it. Open saline, yes. See, I've got the attachment here. The picture is fine, yeah?
Yes, it's fine.
Okay. No. Yes, I got it. Still, in vitrectomy, we've got all the same, mostly. I've got slight reaction, as you can see, sort of a tobacco dust.
Yes.
I'm going for the center. I think she's got posterior vitreous detachment too, but also it's the same. I usually check with the triamcinolone. In triamcinolone, in this case, it's nice because in addition to its enhanced visualization, it got an of course, inflammatory effect in these starting PVR cases. So we've got a twofold benefit from using triamcinolone usually. I think we've got it here. This is the posterior vitreous face. It's already detached, as you can see. Is it obvious?
Yes, it is.
I think it is. But I'll go even for triamcinolone. Guess triamcinolone?
And what's your working parameters? The cutting rate is 5,000 cut per minute?
Yes, it starts, my start point is 1,500.
Okay.
And the end limit is 5,000 when I go for shaving.
And the vacuum?
Vacuum usually is 300 to 600 with the 23 gauge.
Okay.
According to my, I'm now doing the core duty cycle, 300 vacuum, around 3,000 to 4,000 cuts with a core 50-50 duty cycle by the constellation. Okay? I'm injecting my triamcinolone. I disperse it by simple shaking or aspiration. I've got vitreous coming. I change to cutting, of course. I think my tear is here. It's a horseshoe. I don't know. Is it seen? Yeah. I've got the horseshoe tear here.
No,
you
I
see
cannot.
it?
No, I cannot see it.
Huh?
No, I can't see it.
Okay, I'll try to. It's 12 o'clock. I'm trying to turn around there. Do you see it? Got a flap here.
Yeah, yeah.
Got it?
Yes.
Okay.
The edge here.
Is it seen?
No, no.
Do you get it like this? I
Try to minimize the reflections of the light.
You got reflections, too much reflections? Okay. Is it seen like this? Okay. Just give me a minute. I will do indentation to show the break. I'm just removing I've got too much triamcinolone injected. I got a mark, so I'm removing it. As you can see, there's no posterior vitreous face adherent in the center. There is slight blood condensation inferiorly. I don't know if you're following me. There's some organized vitreous down from the
Yes.
break. Do you see it? Yeah?
Yes.
Okay. It's entangled with the posterior vitreous face, so I'm removing them. In these cases, I go for shaving. Of course, the PVR is minimal, so I don't do extensive shaving, but I go for the vitreous base as much as I can. There are two tears, if you can see. I don't know if you see them or not. I'll do indentation so that you can see them. Do you see this tear?
No, it's not.
You can see it?
No.
اوكي اديني هوك يا دينا. لا هوك عادي لا عشان انا ازق.
Ayman, are you using a wide field light or this is a straight?
No, this is a straight line.
Yeah, that's why I
Yes,
think with
yes.
wide field usually the
I'll
view
try
is
to get the
better.
white field. I'll try to get it now. Yes. Do you see this is one of them? Do you see them?
We can see the microscope lens very nicely.
Do you see the break?
The microscope lens.
Yes.
But we can imagine it.
I'll try to get it. تحطيني الدورك عندك؟ اديني نور الدور. يس العادي. حاضر. I've got the trocar coming out. لا لا سيبي ارفعي اللينس انا اقلبي انا اقلب. اقلبي. I've got the trocar coming out with me. So just stand still. Just push it as I go. Okay. Give me no. This is the light I'm using. It's straight light. I'm trying to use. لا الثاني عادي. Yes. No. The other one is. لا الدور بتاعنا. بتاعنا. عشان وايت فيلد. لا نستعمله برضه. ممكن يزنق. You can never tell. I got the shielded white field light.
Okay.
We'll see if it's gonna give us more light on the case. Okay. زودي شوية النور.
Zoom it. Yes.
Is the visualization better or it's the same?
It's better.
Okay. I've got one tear with a flap here. I've got both superior tears. This is one, and this is the other.
Yes.
Do you see them?
Yes, now it's obvious.
Okay. اديني الفلوت needle. I've got a problem with the center. I'm seeing something like an epimacular membrane, if you can see it. I wasn't see it without triamcinolone really, but when you get triamcinolone, it's entangled to it. See it in the fovea?
Yes.
See this, yeah?
Yes.
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 I should remove it. I try, of course, not to touch it. I try to back flush it as much as I can. It's rather dangerous. It's in the center. Do you see it?
Yes.
It's a bad thing that you have this, of course. Don't like it because you are in the center. I try to back flush it. I hope it goes away without me trying to touch it.
Yes.
Yes, thank God. It got away without touching it. It's very bad to happen because you will have to touch the foviola. It's not a nice thing to do really in these cases. Okay. No, not here. I need the vitrectomy. I'll do some shaving. دوسي لي تحت بأيدينا كده. I'll do some shaving of the retina inferior. I've got it attached. Yes, تحت يلا. Sometimes in these cases, I do chandelier. It's not really mandatory, but to do my own indentation, do my own laser, which would be very handy. But Dina, the nurse with me, is called Dina, by the way. She's one of the best. She does a good dentation, really, so I don't need the chandelier. So you either get a chandelier or a good nurse.
Okay.
Ayman, have you tried indenting with the light pipe?
6 o'clock? Sorry?
Have you tried indenting with the light pipe? I'm not trying to put Dina off work, but
Sorry?
I'm not trying to put Dina, your assistant, off work. But have you tried indenting with the light pipe?
With the what?
The light pipe
Yes, I
from
sometimes
outside.
do this, but I do this really sometimes, but I don't get a quite a good view that I like. But sometimes I do it really. Especially in myopic cases, I get a thin sclera and I get a view really, sometimes. And sometimes I do it even with the laser, but I don't get a good picture of the laser spot.
No, with the laser, you don't see the laser. You
Yes.
you see it afterwards.
Okay. روحي على ناحيتك.
So now we have Dr. Amr.
Okay. خليه 300.
ايوه ما انا عارف بس هو خليه سامعني. دكتور عمرو.
ايوه. رياض احنا شايفين
ماشي.
الابريتينال ممبرين السكندري
Yes,
ممبرين.
it's very dense.
Yes, very dense. So, and I have the old cryo marks, extensive cryo marks. And I started by doing PVD, which I found almost done. There is no vitreous attachment now.
Okay.
300, 300.
And you stain under air or under saline?
I'm going to stain under saline. I'm traditional in this technique. I'll use the BBG dye
Mm.
to stain the ILM, and triamcinolone to stain the epiretinal membrane.
Okay.
So what they call double staining.
Okay. And you do prefer the brilliant blue of goiter than the membrane blue stain?
Yes, the BBG is the safest according to the literature now, and the most friendly to the retina. Of course, the best stain is the traditional ICG.
Yes.
Gives the best stain for
Yes.
the ILM,
Yes.
but the toxicity is not acceptable anymore. So there was a shift to Triban Blue, which is something intermediate from every aspect. It's cheaper, but does not stain clearly as the BBG or the ICG, and it is also intermediate in the toxicity. The BBG is the most innocent to the retina.
Mhm.
الانفيوجن 30 هو كام؟ اوكي عايز كينا كورت
Dr. Amr, your viewing system is the IBUS?
Yes, it is the IBIS, yes. Focus. Max. Max. شيل الرمل. الغرزة. الكريل. حطي السبيكلم التاني. السبيكلم التاني. غرزة. Ring. Oh,
Can you please centralize
yes.
your globe?
Sorry.
So you don't depend on the IBUS lens in the macular surgery, you use a special lens.
Yes, I don't rely on any indirect viewing system.
خشي جوه شوية. Yes.
Please centralize the.
You're with me, Ihab? Ihab?
Now we have Ayman.
Yes, okay. I'm just cauterizing my brakes
Yes.
to see them, to doing laser under air. Okay, Dina, go out. Okay. Dini per fluoro. I've done shaving,
Okay.
limited. There is a small piece here I will do. Dini okay, Tom. There's a small piece on the other side. This is physic. I don't want to cross hands. Okay. Zini. Okay. I'm doing a shave duty cycle. Take per fluoro. Okay. Oh no, I'll be injecting perfluorocarbon you have to the edge of my
Yeah.
brakes
Okay.
on the disc. وقفي الحلول. Stop.
You routinely use perfluorocarbon?
Usually, if I have a brake that equatorial or pre-equatorial, I usually put perfluorocarbon because usually our fluid runs to the center,
Yes.
leaving you only with the solution of doing posterior retinotomy. Of course, I've got increased intraocular pressure, so because of you've got a closed system, so I have to go every now and then with one of the instruments, or sometimes if you have the chandelier, you can use it only without the other instrument, leaving it with a flute needle to decompress it. I've got pulsating disc and it's getting white. I'll go out, relieving the pressure, go in again. It's easier, of course, to use a chandelier, or if there's an illuminated instruments if you have. Just go out. I'm going out every now and then. I've stopped my infusion, but still I've got positive pressure because it's valvular technique, so sometimes I go with the continue. I've got it almost at the edge of the most posterior one. اوكي زين تطلعي عايز السوفت تيب اللي عندي السوفت تيب بتاعتي انت عندك سوفت تيب؟ انت 23 اوكي I've got positive pressure coming. Just go out. Fluid needle. لا عادي هنا بس عشان decrease the pressure. You want to decrease the pressure slightly. طيب انت وقفتي المحلول؟ اوكي. زين يا زي ما احنا ليك واقفه. I've got a pulsating disc again. I want to go to the edge of the
لا ضوء الميكروسكوب الجهاز.
دكتور عمرو again.
بس كفايه. هم معايا إيهاب.
ايوه انا معاك.
إيهاب.
Yes.
Yes. Okay. Now I moved to.
Please centralize.
Please centralize.
Centralize.
Okay now.
Yes.
I shifted to the bulk central area lens. It gives two-fold magnification, and it just gives the central 15 degrees. And I'm using the Alcon forceps in the grasping.
Okay.
And here is.
This is the Gray Haber forceps.
It is a Gray-Haber forceps, and it is a disposable one. Now I remove the membrane. You have some fecal hemorrhages,
Yes.
usually, and this denotes that there is part of the ILM is built with the retinal membrane.
Centralize again.
It's okay now?
Yes.
Okay. Now I'll take off the lens again and use the stain.
Okay.
Okay. شيل العدسة. تموف لأيمن ونرجع تاني بعد ما أعمل stain.
What's the type of this lens, Dr. Amr? It's a Volk lens?
This is a Volk lens manufactured by Volk. It is for the central area only. It is have a convex surface and it just gives the central 15 degrees.
Okay. أيمن أنت قلبت على هوا؟
Yes. Just trying to go with the soft tip Dini forceps. The soft tip, this one is not extensible. لا لا اديني 23 gauge forceps. Just introducing the fluid needle. I got no. Just introducing it because it's not extensible, so I just introduce it with the tip of my forceps
Okay.
because it's valvular, as you know. That's it. Okay. اديني النور. جهز ليزر. زين. زين. احنا حلوين. Yes, I've got the retina getting flat EHAB like this.
Yes.
See it?
Yes.
I'm just checking this is my most posterior break.
Mm.
It's almost flat. I'm just, I done it with the hard tip, but I'm checking with the soft tip to get any residual saline or subretinal fluid. Got the edge of the perfluorocarbon. This is perfluorodecaline.
Yes.
Okay. I think the retina is fine. I'll go for laser. Laser retina.
And you'll use expansile gas. I think you will not use
Yes,
silic.
yes. I've got C2F6 perfluoroethane. I'll do 14% concentration, non-expansile concentration, and it stays usually from 3 to 4 weeks. I think this is enough.
Yes.
We can even, I think, if we have SF6, we can use it because this case looks fine, inshallah. It hasn't got any membranes or severe traction. It's a fresh case.
No, it's beautiful.
No, inshallah. Yes. Just doing laser. خلينا 200. فين go for the foot switch, yes. Okay, thank you. Okay. I'm focused. اديني focus هنا صنع. العكس. Okay, very good. That's it. Is it seen, Ihab?
Yes, yeah.
Okay.
You're using argon laser. This is not a diode laser.
Yes.
This is the constellation laser.
Yeah, yes, yes.
تخرجوش الجهاز ده.
I think this is enough. Take 2-3 rows around every tear. Go for the other one. Switch hands. Fine, switch my hands. Okay. بس كده هنا. احنا قربنا يا سيدي، ما تقلقيش يا ست كل. احنا قربنا ان شاء الله. دوسي لي تحت كده لينا. I'll just do check inferiorly if I would do laser inferior or not, if there is any suspicious areas. Yes. Sometimes in these cases I overdo laser just in case towards you. ناحيتي كده يا دينا. جوه خالص خشي شوية. Yes. I think it's free. ناحية الساعة 4 الناحية التانية. Very good. This is a residual hemorrhage. I won't go for it. Just very near to the lens, equator of the lens, so that I won't hit it. I think this is enough. Okay, line. اديني فلوت نيدل ادينا. Soft. Oh yes. اقلبي كده عشان نشوف. Are you with me, Ihab?
Yes.
Okay. Okay. Go ahead. Hey, Libby? Yes. I'll take my perfluorocarbon.
Okay.
I'll just check if there's any fluid that's trickled at the holes.
Yes.
Before taking the perfluoro. These are my holes. It's okay. I think it's fine, inshallah. I will just take my perfluorocarbon. You can take it with the original syringe that you injected or with your flute needle. Both will do. If you intend to re-inject it, you can take it with the same syringe, of course, so that you won't lose it away.
دكتور عمرو احنا معاك.
Do you have a view now?
Yes.
It's okay or needs to be better? So,
So you remove the epiretinal membrane by the staining it with the triamcinolone,
Yes,
and then
this is the ILM.
ILM.
Okay. Especially in those cases, the ILM is usually partially detached.
Yes.
This area there was no ILM, and that's what I said when I saw the petechial hemorrhages.
Hmm. And you're using a Gray-Haber forceps.
Yes.
Centralize, please.
حد من اللي واقفين يقول لي انزل لتحت ولا اطلع لفوق.
Dr. Amro, do you have a special site where you start peeling your ILM?
Yes, I prefer to start at the temporal edge of the macula. In this particular case, I found the edge down at 6 o'clock, so I changed my preference. But if it is a case of macular hole, I start on the temporal side of the macula.
Okay.
Dr. Amr, is this the ILM and then there's ERM remnant on top? Is that how you see it? Or?
Sorry?
So you're peeling the ILM, but there's ERM remnant, there are ERM remnants on the top of it.
Yes, of course, and this is one of the rationale of doing ILM peeling in those cases.
Right.
Those cases, the pathology is epiretinal membrane, but by peeling the ILM, you are 100% sure that every piece of the ERM is removed on top of it. What I should stress here now is this fault inside the retina. It shouldn't be mistaken with that there is remnants of the epiretinal membrane, because there is always stagnation of the exoplasmic flow and intraretinal edema in those cases, which may give a false impression that there is a second membrane. If you try to move this fold, you will going to tear the retina. How far should we go? It's written that you should go to the arcades, which is here and here now. Still, you can go further if you have a case of macular hole, which is large enough, if you have extensive membranes, but usually to the arcade, as we have done now, is enough to do the job. Okay, now I removed the membrane from the central area. I have still membrane, of course, here. I'll try to remove it. We can now shift it to Dr. Ayman if you'd like.
Okay.
Okay, Ihab,
Yes.
I'm Ayman.
Yes.
I finished Ihab. I removed my trocars. I found this one leaking. I took a stitch here.
Okay.
And I usually inject gas after total closure. I don't inject from the infusion. So I'll go 4 millimeter. This is phakic. I'll go 4 millimeter from the limbus in the most dependent area. Inferiorly. Independent, I'm sorry, area. And I start injecting. And I go with the and I go from the most independent area superiorly, also 4 millimeter with the, okay, with another syringe, insulin syringe 27 gauge, to remove the air. As you know, perfluoroethane and the usual gases that we are using are heavier than air, so they go towards the posterior pole, pushing the air superiorly towards my 27 gauge needle.
Okay.
Are you following me, Ihab?
Yes.
Okay. I keep the one with the gas deeply injected, and the one in my right hand to relieve the air just beyond the sclera to get out as much air as I can, as it is lighter than the gas.
How much volume do you put, Ayman, to make sure you've done the exchange usually?
Sorry?
How much volume do you put of gas? Is it 35 mil or?
Usually 30 to 50. I'm using now 20, but the optimum I would say would be 30 to 50. 50 is the best to get sure you have flushed all the air. I'm using now 20.
And what concentration of gas you're using?
14% perfluoroethane, C2F6. Do you need Q-tip? Just Checking my intraocular pressure. I think I'm fine. I'll go with this one out. Slight tamponade. I think we are fine. And we are finished. Thank you.
Thank you, Ayman.
يلا اديني كيناكورت الباقي. شكرا يا باشمهندس. شكرين يا جماعه. ثانك يو. شكرا يا دود.
دكتور عمرو.
ايوه. انا في اللاست ستيبس بقى I finished the eye limb peeling. I'm now will close on air.
اوكي.
Dr. Amr, quick question. Do you, just for the sake of the discussion,
Yes.
do you do routine internal search before putting air in these cases, or?
You mean the examination of the periphery?
Yes, mainly entry sites.
Yes, of course. I'll do this now. When I put the air, I have a wider view, and it facilitates my examination.
So you check the entry sites under air after after putting the air in.
Yeah, yeah.
Right. Thank you.
Sometimes you have petechial hemorrhage, sometimes you have even minute breaks in the central area. Those should not be laced. Those minute breaks which happen in the area between the arcades, they are usually do not cause any harm. So you don't have to lace them. trying to lase them, we may induce CMV. Now I'm going to check the periphery. After closing the sclerotomies, I put some saline to make sure that there is no leak of air from the sclerotomy. And now I remove the infusion, and that's it. The globe is firm now, 25 to 30 millimeter mercury under air, and that's it. Thank you.
Thank you very much. Beautiful surgery.
تمام. متشكرين يا دكتور عمرو.
الحمد لله على سلامتك، تنام على وشك لغايه بكره الصبح.
Now we've finished the first session of today of the life surgery. We will have a lunch break, and afterwards we have a symposium moderated by Professor Dr. Saleh Sharif, the head of our vitreoretinal department, which will start at 3 p.m. Inshallah, 3 p.m.